Hi, this is Elliot Fishman, and welcome to the July 2025 CTisus quiz. It's hot outside, it's humid outside, it's typical July in Baltimore, but we're inside, and we got 10 cool cases to help cool you down. Anyway, let's get started. The most likely diagnosis in this patient with right lower quadrant pain. Well, what do you see? Thickening of small bowel, prominent fibrofatty proliferation of the mesentery. You see the vasa recta are very prominent, and the mucosal enhancement in areas of narrowing. All the things I just described are perfect for Crohn's disease. Appendicitis, this is not the appendix, it's a small bowel. Salmonella does involve the distal small bowel, but the loops are typically edematous, not disappearance. And GVH can be very extensive involvement of both small and large bowel, but not the kind of mucosal enhancement we see here, and not the areas of narrowing. This is just a wonderful example of Crohn's disease. The most likely diagnosis in this patient with hematuria is, when I looked at the axial images at first, I saw a mass infiltrating the upper portion of the right kidney. I could not separate it from the liver. It encases the renal artery, and I was thinking lymphoma. When you look at the coronal, it looks more typical for being a large mass, which pushes you to something like a clear cell or papillary renal cell carcinoma. Obviously, this is not pyelonephritis, and it doesn't have the well-defined margins and enhancement of an oncocytoma. The fact that I don't see any real adenopathy, the fact that it looks so mass-like on the coronal views, I have to go with clear cell, though. What does bother me with clear cell is the lesion is not very vascular. So, I don't know, I'm hard-pressed to get away from lymphoma, and I probably would read this as a big renal mass lymphoma versus a renal cell, maybe even a papillary, though that's unlikely. This ended up being a clear cell renal cell carcinoma, which does make the point that clear cell has a wide range of appearances. The most likely diagnosis in this patient with chest pain is, so we have a cardiac CT, and you can see I'm just showing you the right coronary artery. You can see on the axial images it looks like there's a big defect in the right coronary artery mid-portion, and sure enough, when you do the vessel tracking, you see the proximal right coronary, which looks okay. Then you see calcified and non-calcified plaque. Then you have about a 1 centimeter length where there's no flow, and then flow is reconstituted. This is not just simply extensive RCA plaque. It's not Kawasaki's disease, which can occur with a range of cardiac findings, including coronary artery aneurysms. It's not an anomalous origin. This right coronary is coming off where it should. This is a good example of right coronary artery occlusion. Again, you can see it on the axials, particularly when you target down, but the vessel tracking really shows it nicely. The 3D rendering used in this case was a beautiful example of cinematic rendering. I say it's not classic volume rendering. Remember, cinematic is a form of volume rendering. MIPS is a projection technique. Phased array is something we don't do in medical imaging. This is just a really nice example of cinematic rendering. You can see the right coronary artery is occluded. This is the 3D cinematic rendering of a case we've looked at previously with right coronary artery occlusion. Just a really nice use of cinematic rendering. The most likely diagnosis in this case, well, when I look quickly, what do I see? I see a large mass in the region of the head of the pancreas and in the region of the second through fourth portion of the duodenum. The mass is very vascular. Then I look and I see the left kidney, but I don't see the right kidney. This could be a neuroendocrine tumor if that's the only finding, though I have a hard time explaining how it's both looking like pancreas and bowel. Carcinoid, I don't particularly like it for carcinoid. They're more intraluminal. It's not a papillary renal cell carcinoma. I don't see a renal mass. The key finding is I don't see the right kidney. And so what this patient has is metastatic clear cell renal cell carcinoma to pancreas and small bowel and nodes. And the patient previously had right nephrectomy. Remember, clear cell renal cell carcinoma, metastasis, whether it's to liver, bone, stomach, small bowel, or pancreas, are going to be typically hypervascular. The least likely diagnosis in this case is, well, what do I see? I see a large cystic lesion in the region of the right adrenal gland, so I'm going to say it's an adrenal cystic lesion. There's no wall thickening, there's no enhancement. The correct answer is it's an adrenal cyst, a simple adrenal cyst. Theoretically, it could be an old hematoma, though hematomas typically have some increased density, even when they're chronic. Lymphangiomas are usually soft tissue density. Cystic pheochromocytomas, we talk about them commonly, and we do see cystic pheos, but the whole lesion is not a simple cyst. Most commonly, there's wall enhancement and there's central necrosis. If you do have a purely cystic lesion, it's also has areas of solid and areas of bright enhancement. So the least likely would be a cystic pheochromocytoma. Again, this was an adrenal cyst. Lymphangioma, it still should be a little bit higher density, but this ain't no cystic pheochromocytoma. And looking at this case, what I can convince myself is we're dealing with a benign lesion. In this patient, post-motor vehicle accident, what's the critical finding? A very nice example, looking at the axial, you can see the left femoral head is fractured and it's displaced inferiorly. This is particularly well seen on the 3D volume rendering, where the femoral head is dislocated from the acetabulum. It's pushed medially and downward. You can see the patient's external iliac artery, femoral artery, and superficial femoral artery. None of them are injured. You don't see any vascular injury. So what you're dealing with here is a left hip fracture with dislocation, just really nicely shown on the 3D imaging. The least likely diagnosis in this case, well, what I see here is it looks like a mass in the stomach. I think there's some bleeding posteriorly. There looks like ulceration. This could be a big ulcerating gastric cancer. Could be an ulcerating GIST tumor. Lymphoma usually is bulky. We don't see ulcerations, but we can. But to me, this looks like a malignancy. It doesn't look like a benign gastric ulcer where you see some wall thickening. And also you see bleeding here. Of course, bleeding can be seen in a benign ulcer or a malignant ulcer. But just the appearance of the stomach, the bulkiness of the stomach, makes me think about a malignancy. This ended up being an ulcerating GIST tumor, but the least likely diagnosis is a benign gastric ulcer. The most likely diagnosis in this case, when you look at the images, you see two things. Image on the right, you see bulky para-aortic adenopathy. An image on the left, you see a mass in the patient's left testes. Now, you can have a seminoma, which can give you adenopathy, right? And adenopathy from testicular tumors is often low CT attenuation. You can have lymphoma primarily arising from the testis, and then you have adenopathy as well, though the nodes typically aren't so cystic, but that's a possibility. You can have an abnormality to the patient's testes if you have trauma, but that would not explain the para-aortic region, and I don't see an appearance suggesting trauma to me. And a teratoma is indeed a possibility, but usually dystrophic calcifications and a larger mass. The best diagnosis in this case is a germ cell tumor with adenopathy, a very, very common form of a seminoma, a really nice case. The most likely diagnosis in this case, what do I see? I see a mass of the esophagus. There's some high density which looks like blood. This is not the look of achalasia where you see the entire esophagus dilated from the thoracic inlet down to the GE junction. I don't see a mass or a stricture here, and this is definitely not a hiatal hernia. This is a large, bulky esophageal cancer with obstruction and infiltration. A really, really nice example. A little bit atypical, but really the only thing I could go with. I could have considered lymphoma as a possibility or metastasis to the esophagus, but a primary esophageal cancer was the correct answer and the best answer in this case. Well, those are 10 terrific cases. I hope you enjoyed them, and I hope to see you back here a month from today. Have a great day, everybody. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.